It's a case of a 61-year-old patient who had an event approximately 1 year ago. And I'll tell you later what this event was because I don't want to give away the diagnosis right here. But after that, he really felt poor, and he was doing worse and worse and worse. And somehow we were kind of worried what was wrong with him because we could not really explain his symptoms. So we performed an echocardiogram, and this is the echocardiogram of this patient. Okay, I'll start again with, I'll skip the bad images and I'll show you the nice images right away. Okay, this is the 4-chamber view. Look at the left ventricle, especially left ventricular function, obviously, because left ventricular function would maybe explain his fatigue, because when we explored him in more detail, he did say that he was not really doing so well with exercise, and he was always hypotensive, and he was trying to ride his bike, and he just couldn't really exercise at the capacity that he could before. Now this is the 2-chamber view. Again, look at the wall motion abnormalities, and look at the regional wall motion abnormalities, and especially also at global left ventricular function. Here is the left atrium. This is the right ventricle. Here we measured the right ventricle with 46 millimeters. Let's just now compare maybe the size of the right ventricle with the left ventricle. Now, you probably want to know if the patient has tricuspid regurgitation. He does. A very weak signal. So maybe something that you should also try to do if you try to get the tricuspid regurgitant signal. Use a small sector. Try to keep it as narrow as possible. It doesn't make a big difference if it's long or not, but it should not be very wide, because that way you have a much better sensitivity and frame rate for detecting tricuspid regurgitation. And then stick with the color as long as the patient breathes, because sometimes you might catch the TR better if the patient inspirates or inhales. Okay, then the question now is, how high is TR velocity? This is the signal we got. I don't know if this is really the maximum velocity or not. It's very difficult to really get the TR signal because it was very weak, but I measured something like 2.8 meters per second. It might be more, but honestly I don't think it is much more. Again, another image looking at the right ventricle. Note that I tilted the transducer now so that we see more of the right ventricle. I moved the transducer more laterally. Also look at the septal motion, how the septum moves. This is a normal motion of the septum. This is a view that I took of the right ventricle, which is an atypical view, I would say. Basically what I did was I just rotated around the right ventricle. So I put the right ventricle into the middle of the screen right here, and then I rotated until I got the so-called inflow-outflow view. This is the inflow tricuspid valve. This is the right ventricle, and this is the outflow portion, and here you would actually see the pulmonary artery. So if you want to see the pulmonary artery, you can do that by just rotating around the right ventricle. And basically it's a view very similar to a 3-chamber view. Okay, so again, another view. This is again a view of the right ventricle. Take a look at the way the right ventricle changes its size with inspiration. Mitral regurgitation is mild, I would say. Again, the 2-chamber view. Okay, so maybe if you want to see diastolic function, or this is the signal over the tricuspid valve showing fluctuations. Sometimes you would have higher, sometimes lower velocities. This is the spectrum across the mitral valve. This is impaired relaxation. We have an A wave, which is taller than the E wave. Inferior vena cava, something that I try to do as often as possible, and which you should do especially in patients where you have some form of right ventricular disease or where you're looking for pericardial effusion. So the subcostal view, I think, is very, very important. Okay, now finally I'll also show you the spectrum across the pulmonary artery. This is the spectrum. Okay, now those are the loops that I wanted to show you, but now here comes my question. why is the right ventricle dilated? Is it because the patient has severe pulmonary hypertension? Well, this could maybe explain his fatigue. Or does he have right ventricular volume overload? It should be overload, not overlay. But anyway, does the patient have some primary problem of the right ventricle, like right ventricular dysplasia, arrhythmogenic right ventricle? Or maybe he has coronary artery disease and it is a left heart problem, or maybe something else. And maybe the patient has an atrial septal defect, and this caused dilatation of the right ventricle and is his problem in reality. So I see that there's a pretty even distribution so far. Half of you have voted. Again, pulmonary hypertension, what speaks in favor of pulmonary hypertension, what against. Volume overload, right ventricular dysplasia, coronary artery disease, atrial septal defect. Okay. 72% of you have voted so far. Okay. Let's say 5 more seconds. You have to vote now, unless you won't be within the poll. Okay. So the result is pretty even distribution. Okay. So you can see here's the result. Okay. So there's a pretty even distribution. Pulmonary hypertension is the winner, followed by coronary artery disease and right ventricular volume overload. Well, I will now give you the answer. Again, I'll show you the loops and I will go through the loops and I'll try to show you how I would approach this problem. And then you will see how easy in reality it is. So the first thing we already noticed is that the right ventricle is dilated. You do not even need measurements to recognize that. Why? Because the right ventricle is larger than the left. Usually it should be about 1/3 smaller than the left ventricle. In this case, it is not as large. By the way, if you do not recognize these things and if you still have problems to see these things, don't worry, because as we go along, we're going to add more and more chapters also to our masterclass, and you'll be learning these things as we go along. This, for example, this phenomenon that you have to have a right ventricle which is smaller than the left is presented in the chapter Heart Chambers. So you can also look that up there. And sooner or later, we'll also add our ebook chapters, and you can read up on most of these things in a few months, I hope. Okay. And don't forget, you can always ask questions. At the end of the session, I will also give you a link where you can add questions and send them to us, and we'll be glad to answer them. But back to this case. So here we have a dilated right ventricle. This is clear. The question is now, why is the right ventricle dilated? And this is a question that you always have to answer yourself if you have a dilated right ventricle. Don't just put it in the report and say it's dilated, who cares? You have to answer the question, and in most instances you can answer the question already with the help of echocardiography. Okay, so there is a question that I see that Amjad asked, may it be right ventricular dysplasia as well? Well, yes, this is a differential diagnosis you could have. Why? Because typically right ventricular dysplasia shows you a dilated right ventricle with reduced right ventricular function and usually a very thin right ventricular wall, where you might also have aneurysms in the right ventricle. Now, I do not see aneurysms here, but all other criteria are present. So in theory, it would be a possible differential diagnosis. But I want to show you something else which comes up in the next image. I think this image, the two-chamber view, is the clue to the problem. What do we see? Again, the anterior wall and the inferior wall. And then in the inferior wall, take a look here. This is absolutely not normal. You see, there is a part of the right ventricle which shows an outpouching, and the remaining part of the inferior wall is akinetic and echodense. What could this be? The patient had an inferior myocardial infarction. This was the event that I talked to you about when I showed you the history of the patient. And the patient was actually pretty lucky because he had an aneurysm here, and he almost had a rupture of the inferior wall. So, Alain, you correctly answered this, and you correctly made a good comment. Yes, it is an aneurysm, what you see here. And the interesting thing is that such aneurysms are more rarely seen in the inferior wall, but you can see them. And this is a patient where I would really be afraid that there is rupture. Now, the infarct or the event the patient had was 3 or 4 months ago. So in reality, once it's over 4 months, you would not see rupture anymore. It's because the tissue is so fibrotic that there is no rupture. But the main point here is he had an inferior infarct, and if you have an inferior infarct, there is also the risk that you might have what? Does anybody know the answer? Does anybody want to answer maybe? Okay. So let's see if there is someone who gives the answer. Okay, perfect. Yeah. So Alain again answered that the question correctly. If you have an inferior infarct, then it's usually the right coronary artery which is affected. And the right coronary artery also supplies the right ventricle. And the risk you might have is that you also have a right ventricular infarction. And what you see here in this apical 4-chamber view is a right ventricular infarct which also affected the right ventricular free wall and caused a severely reduction in right ventricular function. Look at the right ventricle. It hardly moves. It is completely akinetic here. And even if you go to the view, the atypical view that I showed you, where you now would see a different part of the right ventricle, you can see that it's thin and not moving. And symptoms that you have with right ventricular infarcts typically is hypotension, fatigue, and right ventricular failure. In other words, you would start to see edema of the legs and pleural effusion and so forth and so on. Why do I not think that this is caused by pulmonary hypertension? Well, one thing is, of course, the signal, but you might say, okay, this signal is not good enough for you to believe that there not truly is pulmonary hypertension. But what for me is more interesting is to look at the signal across the pulmonic valve. Let me see where it is. Here, okay. So if you look at the signal here, what you nicely see is that you have a very rounded signal. As a matter of fact, in other words, we have a time interval where you can see that the time from the beginning of the signal to the peak is somewhere in the range of 127 milliseconds. If you have pulmonary hypertension, this is much shorter. You would have a short so-called pulmonic valve acceleration time. So I can exclude that this patient in reality has pulmonary hypertension. This signal also tells me something else. It tells me that despite the fact that the patient has a reduction in right ventricular function, there still is enough flow. So I think even though that ventricular function is reduced, he still has enough flow to not be severely suppressed with respect to his exercise capacity. And finally, the last comment that I would like to make is this patient obviously has a very poor prognosis, because we know that patients with right ventricular infarcts in general have a very poor prognosis. And I would expect this patient sooner or later to get pulmonary edema of the legs and pleural effusions and maybe even more tricuspid regurgitation and so forth and so on.